So that is how the operations work. That's what you can expect in terms of weight loss and follow-up. And I talked about things that you need to do to make to keep weight off in the long term. And now we will take questions. And before I try to open the mics up, let me just say, you can chat. You know, all you guys probably have noticed that you have a chat window there too. And if you want to type a question in, you know, that's a nice way to kind of get it on the list, and so you don't have to worry about remembering it. I'm going to try and open up the mics. We have quite a few people here, and sometimes it doesn't work, but we'll give it a whirl. Hold on one sec. Let me just, ho-de-do. All right, I'm listening. Question? I heard somebody. Or maybe she's talking to somebody else. I don't know. Anybody have a question?
I want to ask about the sleeve and the vitamins.
Okay.
Go ahead. With the sleeve gastrectomy, is there the need for the vitamins like it is with the gastric bypass?
Yes. Categorical, yes. If you take the exact same vitamins with a sleeve as you do with a bypass.
Okay. And what about candy? Is that?
You know, dumping, I think what you're talking about is dumping. And, you know, in general, candy is something that I plan to eat little of, you know. I mean, you know, human beings don't need a daily, you know, RDA of candy. If you want to eat some now and then, you know, that's okay. But, you know, it's very bad for dieting. Not because of the calories you get from the candy so much, although those definitely don't help anything, but candy makes your blood sugar swing wildly, right? And the peaks aren't really so bad unless you're diabetic, you know, but even then, it's not. The real disaster is the trough, because when your blood pressure, or your blood sugar rather, runs lower than normal 2 hours, an hour after you eat the candy, you experience that as hunger. Right? A particular form of hunger that is very difficult to resist or refuse. And that obviously is not something that's helpful for you if you are overweight and trying to lose weight. You know, so in general, less candy is more. If you're talking about dumping, that's something that generally I'll leave to my dietitian to explain. Dumping, in a nutshell, dumping is a set of unpleasant feelings, unpleasant symptoms that patients sometimes get after weight loss surgery, especially the bypass, when they eat foods that are particularly high in sugar, like candy and fat, you know. Not everyone gets it. It's sort of a spectrum. You know, some people don't get it at all. Some people have it significantly, you know, if they eat even a little bit of sugar. The sleeve doesn't exempt you from dumping. I mean, I know you, a lot of people, it's less of a problem, but it is definitely, it's the sleeve is, you can't go into the sleeve expecting to have no dumping. And I can explain to you why that is in the office if in fact dumping had anything to do with what you were asking about. I suspect it did. You're blown away by my answer, I can tell. So was that sort of in the same neighborhood or zip code as your question, or?
Yes, that's fine. I was really asking about, like, when you eat candy, does it go through, like, the drinking with the Doritos, or?
Oh, yeah. Yes, basically. You know what I'm saying? I mean, pretty much most forms of candy they liquefy in your mouth, you know, or definitely on the way down. So yeah, you know, for practical purposes, they're liquid.
Okay.
When you swallow them, you know, chocolate and that kind of stuff, it's basically liquid, you know. So yeah, you're not going to fill up on candy. You know, it's not a good, there's no good solid candy foods in terms of activating the restriction. Can you excuse me just 1 second?
Yes.
Dr. Fitzer. Hey, I'm good. I'm actually doing a webinar right now. I'll, yeah, I'll have to, yeah. Yep. All right, thanks. Bye.
Hello?
Yeah.
Dr. Fisher.
Mm-hmm.
Okay. What I want to know is, can you hear me?
Yeah,
Oh, okay. I didn't know if you could hear me or not. But,
I can.
okay. I'm more concerned about the water. Like I was asking in my appointment, it's like I'm a water drinker all day long. And, I mean, I drink, like, maybe a half a gallon a day. And also I stay dehydrated because of my blood pressure pills. So I guess that's the scary part is I don't want to be out and feel pain and can't take in enough water. And that would be my concern about like a lap thing. It's just that part. It's just the getting enough water in.
Yeah, you can, I mean, you know, the idea with these operations is not to hold up liquids. You know what I'm saying? Even the lap band, if it's adjusted right, you can drink pretty freely, just not around your meal time. You know, and for some folks, that is an adjustment. I mean, not a lot, but there definitely are a fair proportion of us that don't realize it, but that do most of our drinking during our meal. You know what I'm saying? We sit down, we drink, we eat, we finish our drink, you know, and do the same thing later. If you're one of those folks, you need to plan to make sure it happens between meals.
Okay.
But you know, you can get your half gallon down with a band. I mean, you know, that is not a, you know, let's say you're awake 16 hours a day, like the average individual. You know, even if you abide by those no-fly zones around your 3 meals, you still have, you got about 11 hours a day to drink as much as you want. You know what I'm saying? You can do a lot of drinking in 11 hours.
Okay. That's my main concern. I believe is just that part is the water. I'm like a fish. I love my water. Okay, thank you.
You're welcome. Anyone else?
I did send a question on the chat. I don't know if you guys.
Sorry. Yeah, I didn't even notice. It looked like it was clear behind me. Yeah. So okay. Some doctors have a weight limit when it comes to performing the surgery. Do you? Now, I'm not sure whether you're talking about an upper limit or a lower limit. As far as an upper limit, it really, I take it on a case-by-case basis. I do some quite heavy people. I've operated on folks close to, up in the 600s. It really depends. When I feel your abdomen, I can tell if I can complete a weight loss operation on you. As far as do I have a low weight limit, it really depends on the BMI. Your body. Hello? And it depends on the body mass index and
Yeah.
Yeah, so if you have diabetes, you can get a surgery as low as 30, right? Your insurance company might not pay for it. The insurance company will start paying for it at a BMI of 35 if you have diabetes or certain other problems. In general, most insurance companies will pay for it in the absence of problems at a BMI over 40.
462. Yeah.
That answer the question?
0167.
For the gastric bypass, you mentioned that it is done laparoscopically. Where are the incisions made? The incisions, there's 5 or 6 for the bypass. Usually 2 here, 2 little ones there, 1 or by the belly button, and then 1 little one up here. Sometimes just 1 over here. So those are the 5. As far as scar tissue from a C-section, that scar tissue is way down there, and that is not an issue. That is a non-issue. Will the patient have a drainage tube after the surgery? In the general case, I do not use a V-tube. I don't use a drainage. And And I would only use those if if I felt that safety required it. And I would say I put a drain in. I honestly can't even remember the last time I put in a drain. It's probably it must be at least it's got to be at least 500 cases, maybe more. Diarrhea is a side effect of the 3 different procedures. In general, the restrictive procedures do not cause diarrhea. That's definitely true with the lap band. That's definitely true with the sleeve. It's quite uncommon. The bypass occasionally has diarrhea in the setting of dumping, basically. When you eat foods that are particularly, really extravagant as far as refined sugar and also, fat. Some people will have dumping, and part of that is besides kind of just feeling crummy, might be some short-term diarrhea. Some people with a gastric bypass discover that they have a little bit of lactose intolerance, right? That's not rare after bypass surgery. And then if you are, it's usually not bad, and you can usually get away with more solid forms of dairy, for instance, like cheese. But if you're drinking milk, which in general I don't think you should do with any of these surgeries, that can cause some diarrhea. But in general, it's the malabsorptive procedures that cause diarrhea. That's the duodenal switch and the biliopancreatic diversion, and that's really one of the reasons why people aren't crazy about them. That's why they're less popular. At the bottom. Let's see. Yeah, so someone asked me, is weight loss surgery a viable option for patients with past surgeries? And, I'd like to hear what they are, but in the general case, yes. People with lots and lots and lots of prior surgeries can get it. What about replacing an existing lap band with the sleeve? We talk about that. I mean, that's in general, if the lap band has failed, the gold standard is to go to a bypass, right? Because of the nature of of the anatomy after a sleeve, or rather after a band has gone in and out, it is much more difficult to do a technically adequate sleeve than it is to do a bypass that's going to work. And also, it's more risky as far as leakage, right? And in general, in my mind, I think it's definitely it's not a great idea, right? Now, it's
if a band is not
correct. I mean, it's certainly something that we can talk about. I might be talked into it. In fact, it's not contraindicated, and certainly there are some people out there who do it, but I think most people certainly who've been around would agree that the bypass is really the go-to operation if you haven't gotten from a band. Do I give medications after surgery to prevent issues with the gallbladder? Well, my stock answer is no. Right? I'll just the last time that I reviewed the data, what you're talking about is Actigol, and there was no evidence that net it decreased your likelihood of needing your gallbladder out lifetime. We're going to talk about the gallbladder a little bit later. It just seemed like it might push back when you had trouble with those stones, to when you stopped taking that medicine. Someone asked, what's the next step? How long does it take before you can have the surgery? The next step is to come in and have an appointment. I think I see at least one person there's one or two who've already had them here. Danielle, my patient navigator, Harley, who's a nurse in my office, will call people tomorrow, or if they can't get you, they'll send you an email and tell you how to make an appointment, and if they get you, then they'll answer your questions if you have them. And that's really the next step. We need to sit down and talk about the particulars of what you want and what your medical history is. What are the relative percentages of patients getting the 3 procedures? Most patients get the gastric bypass, slightly just over half. Somewhere between 50 and 60% in the United States. Those are the statistics I'm most familiar with. And then the lap band makes a small, it used to sort of be lap band and sleeve, split the difference there. Roughly 50% bypass, lap band and sleeve with the difference. And, 5 years ago it was like, 40% lap band, 10% sleeve. Now it's sort of the opposite. It's more like 40% sleeve, 10% lap band. Those aren't precise, those figures, but they're within plus or minus 5%, each of them. They're accurate to that. So let's see. Does lap band interfere with someone going into menopause? And the answer is no. Flatly no on that one. And has hot flashes. Yeah, the answer is no. The only way that a lap band would interfere with that I can think of is that, around the time of lap band surgery, I will tell you to not take your estrogen replacement for a while because the estrogen can put you at slightly for blood clots. Are there newer versions of a lap band that work better than an older one?
What you gotta do to be able to talk?
The answer is no. I can hear you talking, actually. By the way. Hello?
You can hear us? Hello?
I sure can. Everybody can hear you. So hold on one second.
Okay.
Well, I got one last question here, then we'll do yours. What are the common complications post roux-en-y? Okay. Well, I'll tell you what. That is. We're going to spend the next half talking about that, so I'll just put that one in the back burner. So, what is your question? Hello?
How can you tell? What kind of indicators will let you know if your band is too tight?
How do you know if your band is too tight? Well, that's sort of an essay question. How would I figure it out? I would say, you really have to. It depends what you can eat, right? And how many times a day or a week are you overfilling to the point where it hurts, right? It's something that can be figured out sitting across from you in the office very quickly.
Okay. What about if food is coming up quite often?
Well, again, even with a properly adjusted band, or even a minimally adjusted band, if you're eating the wrong kind of food or food too fast, you can experience that. So to sort it out, it takes a little, we have to sit down. It definitely is not it doesn't sound too great if food is coming up often. I would suspect that you probably, or whoever it is we're talking about, is too tight. Why is the band becoming less popular than the sleeve? Because it doesn't work as well, because reoperations are much more common. The weight loss is less. You have twice as many, even if there's no complication, it requires twice as many office visits. And it requires a needle stick at half those visits, There are dietary restrictions I'll get to that, it's harder to learn to eat with a band. Just as for instance, there are dietary restrictions you have with a band that you don't have with the other operations. For instance, with a band, you can't eat steak. When the band's adjusted to where you're going to be happy with the weight loss, you can't eat steak. Untoasted bread won't go through. Pork won't go through. You don't have those restrictions with other kinds of surgery. It's funny, I just read in the news today that Chris Christie, or that's his name, right? The governor of New Jersey. Is it Chris Christie? Anyways, he got and
he had the surgery.
Yeah, he had a sleeve, and
No, he has a lap band.
Oh yeah, my bad, a lap band. That's right, a lap band. I was thinking band, and I said sleeve, but he in my mind, he's probably not a great candidate for it. I know he just. He's a guy, and his BMI is definitely up there. And anyways, we'll see how it goes. It'll be hard to know because there's a honeymoon period after you get a band for about 18 months, 2 years, where you can be tighter than you're supposed to be and not have a complication. So we're really not going to know what's happening for about 2 years with him.
Yes,
Okay,
I can't wait to see his results.
Yeah. Well, you give them 2 years. So I know people who've had the surgery and they have liver issues. That's because they're doing something wrong. I would say that the people who have liver issues, they have, a lot of patients that I operate on had liver issues before. You know what I'm saying? The modern weight loss surgery, the restrictive operations do not cause liver disease. Now, gallbladder disease, yes, and we're going to talk about that in a minute. But like liver failure, the answer is no. Any other, one last question we can take before we go to complications? Anyone? No. All right. So, moving on. I'm gonna mute everyone again. Nothing personal. Yeah, it is Chris Christie. That's right. Anyways, all right, complications. The starting point with complications is, the natural starting point in my mind is death, right? If you look at numbers coming out of peer-reviewed literature, right, from good centers with regard to their death rates, you'll see that the death rates at a competent center for the bypass and sleeve are about the same. And that's about 1 in 300 or 1 in 400, or 1 death for every 300 or 400 patients on average, with an average risk case mix, right? The death rate is less with the lap band. It's usually 1 in 1,000, sometimes less than that, with an average risk case mix for the band. As for my own death rate, the patients that I consider my own, that I, the way that we sort of count, a doctor's patients, when we start counting essentially is when they leave training, right? I left training in 2006 when I finished my weight loss surgery fellowship. So all the patients after that I consider my own. I have weight loss surgery patients. I've got more than 1,800. And in those 1,800 patients, about 1,700 of them bypass and sleeve, 100 and change band. I've been lucky enough not to have any deaths. Now, deaths can happen occasionally, even with a good surgeon, even at a good center where everything is done just right. The top 3 reasons that people do die after weight loss surgery at a competent center are blood clots, number 1, infections are number 2, and that's usually the result of a leak. Heart attacks are number 3. As for blood clots, whenever a human being goes for an extended period of time without moving their legs around the way ordinarily all human beings are sort of wiggling their legs around all day long. And that kind of thing happens, for instance, on long plane rides, and it definitely can happen when you are asleep on the operating table. The blood stops moving normally through the veins of your legs, right? It stagnates. And when that occurs, you risk forming a blood clot down there in one of those veins. If you do get a blood clot in one of the big veins in your leg, that clot might stay there in your leg, in which case it can make your leg swell up, or that clot might break off and wash downstream to your lungs. And if that clot is big enough when it gets to your lungs, it can kill you, right? Such that even if I'm standing right next to you when it happens, and I have all the help I could possibly want, right, these crash carts and, there may be nothing that I can do to help you. So as you would hope and as you would expect, we weight loss surgeons take these blood clots very, very seriously. We do everything that we can to keep them from happening at all. And those things include giving you as much blood thinner as we can safely get away with before, during, and after your surgery. Keep the blood moving keep the blood as thin as possible. We put the little squeezing pumps on your legs to keep the blood moving through those veins as normally as we can. And also, we work very hard to get you on and off that operating table as fast as we can to give the clots as little time as possible to form. And that is something that my teams do quite well at the 2 institutions at which I operate, and that's one of the reasons why I've never had one of these fatal blood clots. Infection is the second most common cause of death after weight loss surgery, and that is where people think that the band is better than the bypass and sleeve. And for the most part, that is true. It's not completely true, and I'll explain what I mean by that in a minute. It is true, though, that to do a bypass or a sleeve, we have to open and then close up again your gastrointestinal system in a couple of different places. For the bypass, you have a staph line there on the pouch. You got staple line there on the old stomach where the patch came from. You have this connection, and you have that connection. For the sleeve, you just have one big, long staple line, right? And all those places where we open up the GI tract, we need them to heal closed again perfectly every single time. Those places have to heal perfectly and be watertight, or else that stomach and intestinal juice that we need to stay inside those organs, right, your sleeve and your bypass system, that juice leaks out into your belly. And that juice is full of lots of bad stuff. It's basically barf, right? It's got, whatever it was you ate. It's got saliva. It's got stomach acid. It's got bile. It's a bad mix. And so if that mix leaks into your abdomen, you get a bad infection from it. And that's called peritonitis. The infection itself isn't really the big problem. The problem is your body's reaction to the infection, or your body's overreaction, the sickness that you develop as a result. That sickness is something that some people call blood poisoning, but medical professionals call it sepsis. And people die of sepsis occasionally after any abdominal surgery where there is the potential for this kind of a leak, and that includes all kinds of weight loss surgery. Now, most people will not die of a leak, even if they get one. Leaks are treatable, and most people will live through them. The treatment is not especially pleasant, though. Treatment means you will be in the hospital a lot longer than that day or two that you've expected. It's usually on the order of weeks. Sometimes it can be even longer than that. It means another surgery most of the time, sometimes more than one. A leak means sometimes you cannot eat or drink anything through your mouth for periods as long as weeks, even, while we're waiting for that little hole, wherever it is, to close on its own. You can't just close the leak yourself, like with a stitch, go back to surgery and close it with a stitch. It sort of sounds logical, but in practice, it usually makes things worse. It's sort of like a sorcerer's apprentice. You go back to surgery trying to close one hole, and now you got 5 leaks, right? It just has to be weighted out. So the treatment of leaks entails a lot of unpleasant things, but, most people will survive their leak. They'll ultimately get home back to their life and get what they wanted from that surgery in the first place, which, of course, is weight loss. Leaks are rare, thankfully. If you look at numbers coming out of experienced centers, you're going to find that they're probably going to quote you a leak rate for the bypass and sleeve that's pretty similar. Usually it's a little higher for the sleeve, somewhere between maybe 1 to 2.5%. Maybe one patient from 70, one patient from 50 will leak. That's about average, right? And by the way, if you are shopping around surgeons or centers, it's, that's a perfectly fair question to ask of any surgeon that you meet, right? What is your leak rate? There's nothing that is off limits about asking that question. It's fair game. There's nothing that's sort of, discourteous about that or something. And that goes for any outcomes-based question. What's your leak rate? What's your death rate? What's your, how many cases have you done? Blah, blah, blah. My personal leak rate with stapled operations in private practice, and again, I've done just over 1,700 total stapled operations in private practice, bypass and sleeve, is 1. I had 1 leak. That was in New York. That was a gentleman who got a gastric bypass, the Canadian guy. And we left the hospital on post-op day 4, and basically on the way home from Canada, he stopped at Kentucky Fried Chicken and ended up putting what turned out to be most of a 3-piece chicken dinner in his little gastric bypass pouch there, right? And as you might guess, it didn't fit, and he leaked. And he came back by helicopter. He lived, and he still sends me these little balsa wood reindeer at Christmas. But this brings me to an important point, nonetheless, which is that, there is a period of 3 weeks after you get a stapled operation, right, where you need to stick very precisely to the diet that we put you on, because the diet was designed with one main purpose in life, and that purpose is to keep bypass and sleeve patients from rupturing their pouch and leaking, right? Now, the forces that compel human beings to eat things that they know are not good for them, that they probably should not be eating, those forces are very compelling, right? I mean, if it were always just as easy as eating, as my telling a patient what to eat and them doing it, then no one would ever need me to do weight loss surgery on them, right? It's hard to stick to a diet, even temporarily sometimes. But it's very important if you want to get a stapled operation, right? Because the stakes are very high. And that's something that we talk about quite a bit more as we get closer to end of stapled operation, is how exactly to do that. The band is not a leak-free choice, by the way, right? You should be aware of that. To install that band, you have to pass an instrument like this, actually it's real skinny, but you have to pass it here behind the top of the stomach right there. And the stomach in that location is very flimsy and it's easily hurt, number one, and also, when that instrument is going back there, you can't see directly what it's doing. Your view is blocked. And it's very well documented that occasionally in passing that instrument like that, a surgeon makes up holes in the stomach. And if the surgeon doesn't somehow figure out that they made a hole and fix it before they close up and leave the operating room, that hole is going to leak later and cause exactly the same, debacle that you get with a leaking fabled operation. You get sepsis, the whole thing. Now, I've never made a leak like this. I've never made a leak at all during the lab days. And honestly, it's very hard for me to picture doing it because I know the anatomy up in that area very, very well from all of my other bariatric surgery work. However, I'm going to stop short of saying it's impossible for me to make a leak with a lap band, right? Number one of the reasons I'm not going to say that is because, like most surgeons, rather, I'm a little bit superstitious. And the other reason I'm going to say that is that good surgeons have done this, right? We know that, right? That occasionally circumstances, come along where even a good surgeon can be fooled, seemingly, and make a leak. And so, suffice it to say, the leak is not a completely leak-free, or rather the band, I should say, is not completely leak-free choice. So that's leaks. That brings me to heart attacks, which, remember, are the third most common cause of death after weight loss surgery. The thing to understand about heart attacks is that, human beings these days, we are living to be much older than we did in centuries past, right? In the year 2013, a lot more of us are roaming around in our, 50s, 60s, and 70s than ever were before. And so, therefore, a lot more of us are roaming around with risk factors for heart disease than there used to be, right? Risks like, decades of smoking in some cases, high cholesterol, diabetes, high blood pressure. Because more of us are running around with these risks for narrowing or for atherosclerosis of our arteries to our hearts, a lot more of us have those little narrowings in those heart arteries, right? Like you see in the Lipitor commercial, for instance. Most people who have those partial blockages, they don't know about it. Because as long as some blood is flowing through, just like in the commercial, you're not going to have any symptoms. But even those silent plaques can cause big trouble after you get weight loss surgery. Right? And the reason is that your blood gets a lot thicker after you get one of these operations for a couple of days. That's something that most people don't realize, but it makes sense if you think about it. That your blood gets thicker after surgery. Picture the case 1,000 years ago, right? Your great ancestor is walking around out there and he gets hurt, right? And he's bleeding. Maybe he gets bit by a wolf or something. It's not like there's an urgent care, on every corner in 1013 where he can just go and get his bleeding taken care of. His body was left basically to fend for itself. And your ancestor's body figured out that if it thickens his blood up quickly after he gets hurt like that, then he's more likely to survive that injury long enough to, meet a family or have a family and have offspring, right? So all of us inherited that blood thickening after we get hurt trait from our distant ancestors. And the kinds of hurt that will cause our blood to thicken definitely include any kind of weight loss surgery. So 2 or 3 days after you get a weight loss operation, your blood gets quite a bit thicker than normal. And what happens then is that even if you have a heart full of those little partial narrowings, those plaques, even if they weren't causing any trouble before, that puts you at risk of forming a clog in one now. And if it totally clogs that artery, that's a heart attack, right? Those obviously are dangerous. So the thing we have to know is, do you have a heart full of those plaques before we go, march off to the operating room to do surgery? Because if you do, and we know about it, there are things that we can do to make surgery safer. So the way I figure that out is with what's called a stress test. Depending on the particulars of your medical history, I may or may not ask you to get one of those. If I do ask you to get a stress test, it's nothing to be terrified of, right? It takes probably 90 minutes, including the paperwork, and it's painless, basically, and it's worth getting if you need it. So that's heart attacks, and that brings me now to bleeding. Bleeding is a risk of any kind of weight loss surgery, and pretty much any kind of surgery in general. Because, if you cut some stuff, there's, some tissue, there's going to be some bleeding. Now, obviously, when you get surgery, I don't leave stuff still bleeding inside you when I know. I make sure it's all stopped before I pull the camera out. But even so, in every one case, in about 100, and I'm talking about the stapled operations here, the bypassing the sleeve. Bleeding is really exceptionally rare with a band. In every one case in about 100 with a bypass in the sleeve, that bleeding is going to start back up again after I'm gone, right? And it'll happen that night while you're sitting in your hospital bed watching, The Apprentice or whatever. And you probably won't be aware of it, right, because you're going to feel normal. But I will suspect it if you're bleeding on the basis of your vital signs that the nurses are checking on you. That's why they check them. If I suspect that you're bleeding, I will check a blood test to find out for sure. If it turns out that you are bleeding, it is not a big deal, right? We don't panic. What we do is we turn off that blood thinner that, remember, I'm giving you to keep those clots from forming in the veins in your left. The most important time for that blood thinner anyway is when you're asleep on the operating table. So I can stop it afterwards. And when I do stop it, the bleeding usually stops pretty quickly. If the bleeding doesn't stop right away, you might need a transfusion. Either blood to replace the blood that you lost, every once in a while something else to help your blood thicken. If you need those things, you will get them. And again, we keep waiting because the bleeding almost always stops if you just give it some time. If the bleeding is still happening, though, like 3 or 4 days out after your surgery, then that's about the point when I'll be sitting down to chat with you about going back to stop it with our hands, which is very rare. In fact, I can count on one finger the number of times I've done that, and that was a gal who actually was a Jehovah's Witness who really didn't need to go to surgery, who needed a transfusion but wouldn't take it, right? So she did fine ultimately. Bleeding in general, it's rare. It will happen occasionally. When it does happen, it is going to keep you in the hospital longer than you can plan to be there, most likely, but it's very unlikely that it's going to have the potential to turn into something really dangerous. So that's bleeding after surgery. We call that post-op bleeding. Like I said, everyone gets some bleeding during the surgery stuff with cut some tissue. Some people get a whole bunch of bleeding during surgery, like from an injured artery or vein that was accidentally injured. And the reason that kind of thing can happen is that all of us human beings, we look just as different ones of the next on the inside as we do on the outside. And really, we look more different ones to the next on the inside. And sometimes the things aren't where they're supposed to be, right? The arteries and the veins and all the other organs for that matter, right? Some people are just completely backwards on the inside. But, if you do enough of these, as careful as I am to figure that kind of abnormality out ahead of time, if I'm going through these cases every week, if you do enough of them, somebody eventually is going to show up whose anatomy on the inside is so abnormal that one of those big blood vessels will just basically have your name on it, right? And you get some larger scale bleeding. That's not that big a deal at my institutions. We are good at controlling even brisk bleeding like that with our little laparoscopic instrument. But if the bleeding is fast enough that does not look safe for you, then that is when you end up with the open incision, right? That's the kind of incision that a surgeon makes when feels like he needs to get his hands on something quickly. I've not had to do an open incision for bleeding during a weight loss surgery, and that includes my fellowship, so more than 2,000 cases total. It's not impossible, though, that it's going to happen one day, right? It could happen to anyone who's listening, although it's pretty unlikely. So that's bleeding, and now that brings me to reoperations or repeat surgery. What are the odds that if you decide to get one of these weight loss operations, what are the chances that at some point down the road in your life you're going to need another operation to fix a problem that was the result of the weight loss surgery that you had? Well, with the bypass and sleeve, that's actually a pretty easy question to answer, right? And the answer is the same, basically. If you get a bypass or a sleeve and you still have your gallbladder, which is that green thing right there, then the odds of your needing repeat surgery are about 1 in 5 if you have that gallbladder still. If the gallbladder is gone, then the odds go down to about 1 in 20, or just 5%. It's a little trickier with the lap band. In general, I can tell you that reoperations will be more common if you get a lap band. Reoperations, vein patients have more reoperations. For most of the reasons that people need repeat surgery with a lap band, I can give you pretty good figures on how often those things happen, except for one thing, right? And that thing is band failure. The band system, it is essentially a piece of plastic mechanical equipment, right? And like every other piece of plastic mechanical equipment in the world that impacts or that touches moving parts, the band is going to fail eventually. And what's going to happen when the band fails is it's going to leak. Either this connector tube here, is going to fracture where it crosses your abdominal wall muscles from the repetitive stress of you breathing in and out 18 times a minute over the years, or the balloon surface the flimsy balloon surface on the inside of the band is going to fracture and leak from the repetitive stress of those, bites of food squeezing their way by, being pushed by your esophagus over you. And the bottom line is it's going to leak all the fluid out, and what you'll experience if your band leaks is it's going to seem like you just went to your band doctor and he stuffed a needle in and took all your, he completely unfilled you, right? Your appetite comes back and your weight is going to come back. And your weight is going to stay back unless that leaking band is swapped out for a band that doesn't leak. That means surgery. So how long can you count on your band not leaking before you have this problem? And the gospel truth of that question is we don't know, right? The current generation of bands that are going in, both the bands that are approved in the United States by the FDA, they've been going in for, not that long, 6 or 7 years, right? Something like that, the longest one. And so depending on how the current generation of bands I'm talking, and they seem to hold up pretty well, right? And we think that they should be good for 15 years, maybe more, maybe 20. But we don't know for sure. And so depending on how old you are when you get a band, how old you live to be, and how long your particular band decides to last, you could conceivably need 1, 2, even more reoperations just to sort of fix a leaking band, to fix a flat, and that's really a number that's hard for me to give you a good statistic on. For most of the other things, I can give you better ones. Now, as far as statistics of the things that require reoperation, we're going to start with the gallbladder, because it's one of the most common reasons. It is the most common reason bypass and sleeve patients need repeat surgery, and it's pretty common for the lap band. It turns out, so that green thing's the gallbladder. If you lose a lot of weight by any method, even diet and exercise, they said, oh, the heck with the surgery business, I don't want any part of it. Thank you very much, Dr. Fitzer. You click me off and you go on your way. And you find a way, anyway, to lose 70% of your extra weight on a diet, right? You do it on your own. Doesn't matter if you do it on your own, because even losing weight with diet and exercise changes the chemistry of the bile, which is what your body stores in that gallbladder, changes the chemical composition of your bile in a way that makes it form little specks of cholesterol. And in a certain fraction of patients, you get that weight loss, those little specks are going to form stones, gallstones, that are big enough to clog up the tubing here at different points, right? And the bottom line is that 1 patient in 7 who experiences the kind of weight loss that you get with surgery is going to have trouble with pain from those gallstones. The most common symptom is pain right here. It's called biliary colic or cholecystitis. It's something that starts showing up maybe at the earliest 3 or 6 months out after surgery. If that pain shows up in you and I can figure out that your gallbladder is the reason, then I'm going to recommend to you that you let us take it out, or somebody needs to take it out. And the reason that your gallbladder needs to come out is that if it does not come out, that pain is going to keep coming back. It might be 6 months between attacks, it might be a week, probably going to be more like a week. But it almost certainly is going to come back at some point. And sometimes the pain comes back as something worse than just pain, right? It can come, and the pain is pretty bad, but it can come back as pancreatitis, which actually can put you on up in intensive care for 6 weeks at a time. It can make you very ill. So if your gallbladder starts to misbehave, you should get it out. And getting your gallbladder out really is nothing to be terrified of, right, in the year 2013. It is a minor surgery. It's safe. It's day surgery almost always. It's laparoscopic. It takes like 15 minutes. It is not a big deal. However, 1 patient in 7 who gets weight loss surgery and still owns that gallbladder is going to need surgery later to get it out. And that's something we should be aware of. The only other reason besides the gallbladder for which we end up reoperating on our bypass patients in numbers large enough that it definitely needs to be talked about up front is for this thing that's called an internal hernia. That takes a little more imagination to understand than that gallbladder over there. So this small intestine here, this is your small intestine. The small intestine is different from all the other organs in your abdomen, like the gallbladder and the colon and the liver and the stomach. It's different in that, unlike that other stuff, the small intestine isn't really fixed securely in one spot, and it can sort of float all around. So what happens is this piece of small intestine over here, after your bypass surgery, where I put these things together, I sort of made these upright. What if this piece decides to sort of shoot a field goal? And it goes dink, 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 dink through the upright, and now it ends up over here, sort of out on a limb like that. You got that piece of intestine over there. That's an internal hernia. this piece of intestine isn't supposed to be over there in these sort of pinchers here. The pinchers didn't really exist before surgery. So what's the problem? The problem is every day that piece of intestine sits sort of out on a limb like that, there's a small chance that it's going to find a way to twist and kink, basically, where it would sort of be like you kinking the hose. You know, if you kink the hose, the sprinkler turns off because the hose is now obstructed. Well, if you kink your bowel and your bowel gets obstructed, human beings experience a bowel obstruction. That's crampy belly pain and vomiting. Now, there are lots of things that cause crampy belly pain and vomiting that can happen to anyone that don't have anything at all to do with weight loss surgery, right? And at my age, 41, I turned 42 May 20th, I've certainly had my share of them, stomach flu, food poisoning, appendicitis, constipation even, blah, blah, blah. It's not always possible to tell the difference between this hernia and all that other stuff would be nice things that patients want you to use, right? Things like x-rays and blood tests and CAT scans and feeling on their belly. Sometimes those things do work, actually, but they're not completely reliable. The only thing that's 100% reliable at finding this hernia over here is putting the camera back in the belly button. Let me clean this up here. Putting the camera back in their belly button, that little skinny camera, right, to take a look. So look at this space with your eyes. So if one of my bypass patients comes back complaining to me at some point after their surgery of crampy belly pain that is suspicious for this, if I can't find a way to convincingly blame their problem on some issue that does not need surgery, something else, stomach flu, then I'm going to want to put the camera back in their belly button and make sure that the hernia is not lurking in there, right? And the reason that I want to do that is that if I don't do that, if you leave the hernia over there long enough, you risk it rupturing. It can, there's a small chance it can rupture, kind of like the appendix can rupture. And if that happens, the patient gets very sick from this. There's no reason to risk letting someone get that sick from this problem, because fixing this hernia is even faster and easier and safer than taking out the gallbladder. And literally, if the gallbladder takes 15 minutes, it takes 10 minutes skin to skin to put the camera in and make sure there's no hernia in there. If there is a hernia in there, you just pull it out, sew the space shut so it doesn't come back, right? About one patient in 20, at some point in their life after a bypass, they're going to have some kind of suspicious crampy pain that is going to make a surgeon suspicious enough that he's going to want to put that camera in and take a look, right? About 1 in 20, 5%. Probably only half the time when we put that camera in is the hernia actually over there, right? Maybe even a little less than that, right? We don't mind coming back empty-handed half the time as long as we catch this every time it's there, because it's important to fix this problem. So again, 5% of patients, 1 in 20, are going to need to look. Probably only half of those guys, maybe 2%, will actually have this. The reason is we're getting very good at sewing the space up at the time of surgery, so this doesn't ever have a chance to happen. But it still happens every once in a blue moon. It's probably, your lifetime risk probably is less than 5% these days of needing the camera in for this, but that's what I still quote people. So anyways, you put that 5% lifetime risk together, or rather 5% lifetime risk of needing the camera in for hernia together with a roughly 15% or so risk of needing the camera in, slightly more than 15%, 15%-ish risk of needing the gallbladder out. It's about 1 in 7. You put the 1 in 7 together with that 1 in 20, and that's how you get your roughly 1 in 5 or 20% chance net of needing repeat surgery if you get a gastric bypass and still have your gallbladder. You have the same 20% chance of needing repeat surgery net if you get a sleeve and you have your gallbladder. About 15% of that comes from the gallbladder itself. The remaining 5% is it's mainly obstructive problem. You can't get an internal hernia with a sleeve because there's no upright, but you can still get an obstruction, right? When you take that, when you do a sleeve and you take that piece of stomach out, you have scar tissue on that cut edge there, and there's some other scar tissue around. Whenever you have scar tissue, you can have pinking of the intestine. Is the bottom line. And so some people will have that. It's pretty uncommon when you operate in the upper abdomen, but it can happen. So maybe 3% of patients, 1 patient in 30 or so will need repeat surgery for an obstruction. Maybe another 1% would need repeat surgery for a stricture. Sometimes for some reason or another, when the stomach heals, it can just become overly narrow in one point or another. Or sometimes It's not overly narrow, but it just lies with a kink. So it's not a nice sort of banana-looking swoop the way it lies. It's sort of, and it kind of looks more like this. That's maybe 1%. And then, the remaining 1% of patients that need repeat surgery after a sleeve need it because they have heartburn, right? The sleeve is an operation that generates heartburn. Is the bottom line. Not everybody has heartburn. Certainly, some people have heartburn before they get a sleeve and it's better. But a fair number of people will get a sleeve. They've never really had heartburn. Now they wake up and they do, right? And it's bad enough where they feel like they need to take some medicine, like an antacid medicine, like Prolapse or something every day. Maybe 1 in 5. Maybe 25% of patients are going to wake up with significant heartburn. Of those patients, the 1 in 4, 1 in 5 that wake up with heartburn, there's going to be the occasional one who's not really even happy with how life is on the antacid medicine. He's having heartburn symptoms. Maybe the acid's better, but it still feels like it's washing up. Maybe he's developing a cough because of it. And he's not going to be happy, and he's going to want something done. And so if you need to do surgery to fix this heartburn reflux issue from the sleeve, the sleeve is the one operation that is not reversible. Because after this piece of stomach comes out, you can't put it back in. So there's nowhere to go with the sleeve but forward. You have to turn it into a bypass, right? Which is pretty easy to do, actually, because if you do a sleeve, you've actually done, that's most of a bypass operation. Conversely, if you do a bypass, it requires that you do most of a sleeve. It's actually, in any case. So how often does this happen? It's like less than 1% of sleeve patients in general, but it's not zero, So anyways, 1 in 7 sleeve patients will need that gallbladder out if they have it, and 1 in 20 will need surgery for another reason. You have small bowel obstructions, you have a kinked tube, and you have acid reflux up here. So put them all together, you get your net 1 in 5 chance. So that's bypass and sleeve reoperations. There are different reasons people need reoperations. For the lap band, we talked about fix-a-flat. We already talked about gallbladder. That still applies to you if you get a lap band. Next most common reason is for a slip or a prolapse. Right? So what's a slip? We said the pouch above your band is the size of a walnut. Right? It's tiny. So what happens if a patient one day decides to try to stick a submarine sandwich in their walnut-sized band pouch? Well, it's not going to fit, obviously, right? Your esophagus does not know that, and it's going to give it a try anyway. And the esophagus is very, very strong, it turns out, right? The esophagus can pump food every bit as strongly as your heart can pump blood, right? Maybe even an athlete's heart can pump blood. That's why I can push a bite of a cheeseburger from there to there in 3 seconds flat. It is powerful. And it's going to try and jam that submarine sandwich into your little pouch with a lot of power. And that's going to try to distend it, and it's going to tend to try to push the band lower on the stomach to make more room for that incoming food. You could really think of it more correctly as it's going to try and pull some more stomach above the band. So we sew that band into place securely, and it's going to pretty stubbornly resist being slipped out of position like that. But the more someone does try to overfill this pouch like that, right, the more likely it is that one day they're going to succeed. And now, the band does slip down out of position, and now instead of a walnut-sized pouch of stomach above the band, you have an orange-sized pouch. That's a slip or a prolapse. The problem with those is that the band is no longer going to work right? It's not going to do what you want it to do. It's probably going to feel too tight. Sometimes it feels too loose. A lot of patients have heartburn. But it's not going to do what you want, which is, remember, to make you feel long-lasting satisfaction from a very tiny amount of carefully, conscientiously eaten food. And if you want that to work again, it's going to need surgery to put that orange back underneath the band, right? So it's just a walnut above it again. So how long can you expect to live in peace with a band before you have trouble with this? In the early days of band results reporting, it looked like this was going to be quite rare. The early reports coming in 2001, 2002, 2003, on average, in something like 5 or 6 years' time, it looked like maybe 2% of patients would need surgery for this, like 1 in 50. But more recent reports make it look like it's going to be much more common. In fact, there are reports with large numbers of patients that make it look like in 5 years' time, it's like, one patient in three, like, 33% of patients will need surgery to fix a slipped band. That's a lot. I think a good median number to have in your head for how often a patient can expect to need surgery for a slip is probably 1 in 10 in 5 years' time. 1 in 10. And I think your risk of needing a surgery for a slip has a lot to do with how disciplined you can be when you are living day to day with your band. And living day to day with a lap band requires more discipline. There are more rules, and they have to be observed. I already talked about how it's trickier to eat with a band. I can't, it's an essay question describing all of the, the ways that sort of eating with a band is different than a bypass and sleeve. But I'll just give you, for instance, right, there are food restrictions with the lap band. And I guess I mentioned that earlier. When the band is tightened to where you will be happy with your weight loss, when it's going to be tight enough to give you even that 45%, some foods won't go through it, right? And remember, I said I want you to eat, in general with these operations, I want you to live on solid food, the most solid food that you can, comfortably eat without trouble. With the bypass and sleeve, there's no limit. Tough steak, doughy bread, tough bagel, whatever. Dry pork, you can eat it all. As long as you take small bites, chew well, go slow. Again, with the band, when it's tight enough, even a small bite of well-chewed steak is not going to go through. It's going to stick. When you try to eat it, you're going to probably make a face like that. And then you're going to have to excuse yourself to the restroom to reproduce that steak, right? So you really need to be, have the discipline to just avoid steak. You need to understand going into it that steak is off the menu. You know what I'm saying? And if you are, and so that, you need to be able to eat in a way where you're not overfilling your pouch above that band much. If you're overfilling it more than once every 3 weeks or so, you are on a collision course with a slip. And it takes a lot of discipline to keep from overfilling it like that. I mean, there are lots of different things. Besides food choice, there are lots of different things that can go wrong. I mean, food choice has to go right. But, other ways it can go wrong. For instance, you need to make sure that you have 20 or 25 minutes to eat, because that's how long it's going to take you to get that half a cup, 2/3 of a cup of food through your band when it's adjusted right. Food, the consistency, for instance, of something, say like potato salad, thick potato salad. It's going to take you 20, 25 minutes to eat it, not because Dr. Fisher wants it to take 25 minutes, because because I'm going to tell you to sit there and drag it out even if you could eat it faster. It's going to take you 25 minutes to carefully eat, get that 2/3 of a cup through your band without overfilling to the point of pain. If you try to eat, even though it's not steak, you try and take down that whole cup right away, it's going to feel just like steak. So you need to make sure that you have the discipline not to be tempted. Oh, I don't have time to try and eat, slowly and patiently today. You can't fall for that. You can't try and eat it faster. And there's lots of other ways that, things can go awry. So it takes more discipline than that, suffice it to say for now. So that's slip. That brings me to port malfunctions, right? There's your filling station. The port has to work, because we have to be able to, adjust your band. There are different things that can go wrong with that port. It can leak, so it doesn't hold the fluid. The tube here can kink, so I can't get any fluid into the band. The port can flip over, so I can't stab it with a needle. It can get infected. If any of that stuff happens, it needs to be fixed. And that means surgery. Now, granted, it's not major surgery, to revise or fix a band filling station, but it is surgery. And in 5 years' time, it's about 1 patient in 20, or 5%, that will need that. So, port malfunction. Next most common reason for reoperation after the band is for what's called an erosion or a migration. And what an erosion is when a band patient gets an ulcer on their stomach underneath where the band is sitting, right there. And when that ulcer chews all the way through so that it's now a full thickness hole, that's when we officially start calling it an erosion. So if this patient has an erosion, if we take that band off, right, put it to the side and inspect the stomach right there, you're going to see that little hole, full thickness hole. You can put your eye to it and watch the food go by. So what is the problem with that erosion? Well, the problem is that the band needs to be sterile, the whole thing. We go to very great pains to make sure that it stays perfectly sterile when we install it. Now that the food has free access to your band, sort of washing in, the gravy that you just ate, it gets infected, right? It gets dirty. And this usually comes to our attention when the port gets infected over here, right? That infection sort of marches up the tube to the port, and the port gets infected. And this can happen, these erosions start coming in anytime after about 9 months. And so a patient's home, they're 2 years out, they got their 45% weight loss. Chris Christie is home, he's happy, sitting in the governor's mansion, brushing his teeth one morning, and looks in the mirror, and hey, I see a red spot down there. Ow! From a long time ago, he probably forgot this conversation about these erosions, but he's going to know something's not right. So he's going to go see George Fielding, who I know, by the way. He's actually a nice guy. He's an Australian guy, and he's very laid back. And anyways, George Fielding's going to see that band thing, the red port site, and he's going to be like, oh no. Because he knows one of two things is wrong. Or what would an Australian say? Blimey. He thinks that he will say, what he hopes is wrong is that the thing just got infected the last time George stuck a needle in it, right? We sterilize the skin with alcohol to kill those germs before we put a needle in it, but you can't kill everyone, right? And if the wrong germ grabs the tip of that needle, if you push it through the skin, it can cause an infection. And that's what George will be hoping, because that's pretty easy to fix. The alternative is he can get this erode. So how does George tell the difference? How does a band surgeon in general tell the difference? You do an endoscopy. You put a little flexible camera down the governor's mouth, and you park the tip right there, and you look this direction, and you see, you take a look. And what you do is you inspect the lining of the stomach right there where the band is sitting, and you can see where it is. And what you hope to see is that that lining is nice and smooth and happy, and that there are no holes. Because if there are no holes, there's no erosion, hooray. It's just a port malfunction or a port infection. That can be fixed pretty easily. The alternative is that you do see a big fat hole there, because if there's a hole, you diagnose an erosion and the jig is up, right? There's not a problem that you can ever clear while the band is still in place. Everything has to come out. Band tube port comes out. The infection will clear after a couple months, and at that point you could talk about doing another kind of weight loss surgery. There definitely are surgeons out there who would be talked into putting in another band. I'm sure George has done that. I personally don't believe I would ever be talked into that. And the reason is that it's going to be, George actually gets paid a lot of money by lap band, incidentally. But I personally would not do it. It's going to be very precarious, much more precarious getting a band in again in the setting of a healed erosion. And, I just don't think it's worth the risk. And also we know that the risk of having a second erosion is even greater than the first. I've been referred a couple of erosions from other practices. Thankfully, I haven't had my own yet, and they wanted bypasses, and that's what they got, and that was no problem. These erosions are quite rare, thankfully. In 5 years' time, it's less than 1% of band patients that will have to deal with it, like 1 in 150. So you put all those things together for which you might need recent surgery if you have a lap band. You got erosions, you got port malfunctions, you have slips, gallbladder, leaking system, that's a lot of stuff. And, in the old days, the lap band site used to quote like a 25% risk of reoperation. And frankly, that number to me just always seems just wildly conservative. I mean, if you get a lap band and you are 18 years old, in my mind, your risk of reoperation effectively is 100%, maybe 200%, you may need more than one, honestly. It goes down from there, and, it's certainly higher than the bypass or sleeve. So that's reoperations. Home stretch here, people, by the way. The ulcers, stomach ulcers are a problem of the bypass and to a slightly lesser extent of sleeve. Anyone can get a stomach ulcer even without weight loss surgery. After you get a gastric bypass and to a lesser extent of sleeve, you have an increased risk in getting stomach ulcers. With a gastric bypass, the part of your stomach that you get on is this part, the pouch part. Now, in general, the increase in risk of ulcers is not high. And for the most part, people who do not do things that give them additional risk of an ulcer will not have trouble with it. The things that give you extra risk of an ulcer if you have a gastric bypass are smoking, and that is far and away the most important thing, but also taking the medicines that people take for arthritis, right? These so-called non-steroidal drugs like ibuprofen, Aleve, Malfunction, Celebrex, aspirin, etc. Smokers have the worst trouble. If you smoke after a bypass, better than 50-50 chance that, at some point you're going to have an ulcer. And if you get an ulcer from smoking after a bypass, you're not going to be able to make it heal with antacid medicine. It just won't go away. The only thing that will heal it is quitting smoking. On the other hand, people who have arthritis, they have an easier time than do these smokers, right? Most of the people with arthritis, after they lose weight with a bypass, they find they don't depend on those those arthritis medicines as much as before. But if they still do, if they still have to take them, they can get away with it, unlike the smokers who can't, right? As long as the arthritis patients protect their pouch with the right antacid while they're taking those arthritis medicines, they can get away with them. But when I'm talking to you about antacids that protect your pouch from arthritis medicine, I'm not talking about stuff that you chew like Tums and Rolaids. I'm talking about prescription stuff, Prolapse, Prevacid, Nexium, Peritonitis, those kinds of things. The place you get an ulcer when you get a gastric bypass, I said it was the pouch part of the stomach, but specifically it's the edge of the pouch, right here there on the margin where it's next to the intestine, right? The margin, right there. And that's why it's called a marginal ulcer. And every day that ulcer sits there, your body will try to make it heal and go away, right? The way your body tries to make an ulcer heal, it actually is the same way it tries to make everything else heal, right? And that is by laying down scar tissue around the problem, in this case the ulcer. So that tissue is going to accumulate there, right? And you may, if the ulcer doesn't heal and go away for good, you may wake up one day and discover that now you have accumulated so much scar tissue that it's narrowed the opening a little bit narrower than it's supposed to be, right? Ordinarily, the opening out of a gastric bypass pouch is decently sized, right? Certainly the narrowest diameter out of a bypass or a sleeve, it's at least the size of a nickel, maybe a quarter. Very rarely that someone finds a way to get something stuck in a normal size, in a bypass pouch with a normal size opening. It almost never happens. Once that opening constricts down though to smaller than a dime size, stuff will start getting stuck, right? All of a sudden, the solid food that you'll notice, the solid food you used to eat and enjoy, right? And remember, that's what I want you to live on for the most part after any of these operations. Suddenly, it's going to feel like it's getting stuck right here. Oh, and you're going to make that same face and have to excuse yourself to the bathroom when you eat it. Liquids will still go through it first before it gets real narrow. That's what it feels like to have this narrowing. It's called a stricture or a stenosis. It is almost always smokers who get this, right? Smokers get this, and that's because smokers are really the only people usually who have ulcers hang around long enough to get that much scar built up. Every once in a blue moon, maybe one patient 500 or less, the way, depending on your technique, but with a linear stable technique that I use, one patient in 500 will get one of these even though they don't smoke, right, or less. And what happens to them is, and it'll always happen in the first 10 weeks, and what happens is the pouch here heals to the intestine here, a little too tightly the first time around for some mysterious reason. In both patients, the smoker and the non-smoker, I can fix this without surgery. It just requires that I put that same camera down your mouth that that endoscope that we use to look for the erosions. And this time I park it there and I look to see if the opening is too small. And the fact of the matter is, it usually isn't. 9 times out of 10, when I put that scope down, at least in the patient in the first 10 weeks after surgery, 9 times out of 10, they don't have that stricture, right? What happened was that you can simulate for yourself pretty well a stricture by eating, even if you don't have one, just by eating too quickly. And, most people don't have it. If, in fact, someone does have it, it doesn't need surgery to fix it. Typically, there is a little balloon. There's it's like a hot dog-shaped balloon, basically, that you thread through the scope, and it stretches the thing back to normal. Doesn't need surgery. So the last thing I have to tell you about is vitamin and mineral deficiencies. The bottom line is that you're at risk for those after any kind of weight loss surgery. The risk is greatest with the gastric bypass, followed by the sleeve, followed by the lap-in. So why is the risk greatest with the bypass? Well, most people assume that it is because of how the doctor fiddled around here with your plumbing to do the bypass and how that's left you less able to absorb the vitamin. There's a kernel of truth to that. Now, there is a modest decrease in how well you absorb vitamins and minerals after a bypass, but not calcium, or rather, but not calories. Or calcium, no, yeah, calcium is not absorbed right. Calories are. Calories are absorbed normally, remember. But even the modest decrease in how well you absorb the vitamins and minerals, right, that is not the reason that's not the main reason that you have the highest risk for deficiencies with the bypass. The main reason is that if you're doing the bypass the diet after a bypass, the way I want you to do it, in other words, if you are, you spent some time working on those 4 things, then probably you're going to find that later on during, the average day, you're probably going to take in less than 1/5 the amount of calories you used to take in. Less than 1/5. That's a 4/5 or an 80% decrease in how much was coming in, or how much food is coming in, and that's substantial, obviously. So you also see an 80% drop in the vitamins that used to be coming in with all that food. So you put that 80% drop in vitamins on top of an even modest drop in absorption, you're way down there with the vitamins that are coming in. No matter how brilliant you can be with the food pyramid, you're still not going to turn that last little, bit of vitamin intake into a menu that is completely free of risk of any kind of deficiency. So the solution to avoiding deficiencies with all these operations is the same, and it is not to worry about the food pyramid. I mean, try to eat healthy food, yes, but take your vitamins, and that's the answer. Take your multivitamin with iron twice a day, gram of calcium a day, and your B vitamin. I think, everyone should do those things, before surgery anyways. If they did, we would find, many fewer vitamin deficiencies in non-surgical patients. But, you need to do those things after surgery, and if you do them, it's quite unlikely that you will ever have a deficiency of any kind. We will still check your levels once a year to make sure. So that is it. That is the end of the talk, and looks like the attrition rate was pretty low. Looks like most people survived to the end, which is pretty impressive. Okay. I have a couple of questions left over. Number 1, do you have patients that lose too much weight? And the answer is no. Anyone who loses, remember, you're not malabsorbing with these operations. Anybody who loses too much weight after a restrictive surgery, bypass, sleeve, band is trying to, all right? There are two settings where that happens. There's one other setting where someone can lose too much weight. And that brings me to the question of reversal, right? Under what circumstances does somebody need a reversal of weight loss surgery? Now, the band's easily reversible. The bypass can be reversed. Sleeve can't be reversed. So, people, as far as people losing too much weight, sometimes it's usually behavioral when it happens. And what happens is this: if you give someone, if you have a person who starts out with a body image disorder, and that person happens to get a very brisk hormone response. Remember the hormone responses that I described, the effect you get after a bypass or sleeve, where your ability your hunger goes way down, your interest in food goes way down. So if you have a person who has a body image disorder, and now you give them the ability to they have no hunger, they can just, not eat if they don't want to eat. And that's a person who just won't eat. And you have unmasked in them, essentially, anorexia nervosa, which is a condition where you always think you're too fat. And the patients, it's not a surgical problem. These patients don't need surgery. It's a psychiatric condition. I see them every once in a long while. And, they usually will avoid my office. You know what I'm saying? When they're 95%, they'll come in. But when they were losing more than that, they know correctly that I'm going to be, I'm going to be concerned about it. And so what usually happens is eventually they go to their family doctor for some reason, and he makes them come to me, he or she. And so they come in, and that's 2 years later, and they're, they've got a BMI of 19 or 18, right? They're underweight, and, I'm like, hey, how are you doing? What's going on? And, I heard from your family doctor, you sort of, thought you should come and see me. I'll be like, oh yeah, okay, great. And then I'll just ask him, how do you feel about your weight? And this is someone who's like, it would be someone who's 5'6", now in 105 pounds. And they'll be like, well, it's okay, but I still have this one little, this one tiny little, and they'll like pull out one tiny little fold of skin like that. that's anorexia nervosa is what that is. That's a psychiatric problem, and that doesn't require surgery. The it can be fixed without surgery. The people who there's one setting where people do lose too much weight and they do need surgery, and that is people who, after a gastric bypass, start smoking again and can't stop and keep having complication after complication related to ulcers. Right? I've seen that happen. Someone will start smoking again. They can have just a string of this, pretty significant ulcer trouble, right? Bleeding, perforations, Some people literally will be in the hospital every month for years, for 2 or 3 years with an ulcer complication related to smoking because they can't stop. And, at some point you just have to sort of throw in the towel and just be like, look, you cannot stop smoking. You know what I'm saying? Let's face that. And we can't just kind of put your name on a hospital room and just, let that be your room. You need to be reversed. So that's sort of the one setting where I think it's, it's appropriate. Is there a liver shrinking diet before surgery? Yes, there's 2 versions, which, I'll give you your choice. You can either have 2 weeks of octafast or 3 days of sugar-free clears, or low sugar clears anyways. Both of those, in my experience, reduce the liver exactly the same. With a sleeve, after the stomach heals, is there a risk of leakage, or is the risk only immediately after surgery? The risk is mainly in the first 3 or 4 weeks after surgery. There is this phenomenon with sleeves that every once in a blue moon it would seem that someone leaks, they leak, even 6-8 weeks out, something like that. It's not clear to me exactly what's happening there. Is it an ulcer? Is it, but that's quite rare. For practical purposes, the staple line risk with surgery is mainly the first 3 weeks. It may be that it sort of was sometimes you can have a little leak and it might take a little while for you to figure it out, depending on whether your body did a good job of containing it or something. So it's not perfectly clear to me what's going on there, but it's very uncommon. So those are the written questions. I'm going to open the mics again and see. All right, anyone have any verbal questions? I hear someone clearing their throat. Anybody?
No.
All you guys want to just throw in the towel because it's 9:30 and probably took longer than you thought. I don't blame you.
No, that's not it. I just got all the information that I needed.
Okay.
But it was very informative because we're honest about all of the complications. So that was good.
Well, yeah, that's the idea. All right. Well, if there are no questions, then why don't we all call it a night? And like I said, somebody from my office, either Danielle or Carly, will call tomorrow or the next day if they can't get you, or they'll at least send you an email. And hopefully I will see some of you folks in the office in the not-too-distant future for a consultation.
Okay.
All right.
Thank
Dr.
you.
Fisher signing off.
Okay, thanks.